So today we're going to talk about why money matters in medicine, and nowhere more so than a place like the operating room or the emergency room or wherever you're getting super powerful, potent IV medications like the ones that I have here. We're going to wait for people to trickle on here um, before we dive into this, but this blew my mind just how much your income determines whether you might live or die after a heart attack. And gosh, like we've known this for a long time. I have a couple videos that talk about the importance of prevention wherever possible, but we already know about prevention being important, right? Everyone talks about that. What we don't necessarily know is that after you have an event, how important is it to take steps that are often natural, that don't need expensive medications that are going to cause you to go bankrupt to prevent a second episode? If you're even lucky enough to, not die in the first couple of weeks or months after the first episode. So I see people coming on here. Hey, Heidi. Well, hello back to you. RJA, good to see you. Jay, Kirsten, I'm happy that you're here. Soph. Oh, and Chem7 is here. I love it. Great. So we have a little quorum. We can start. And Jay. And candidate, social determinants of health. Oh my gosh, of course we can talk about that. That's part of what we're going to talk about right now, because believe me, the social determinants of health play a huge role, even in an operating room like this. You see the lights behind me, the TVs, the life support. What you bring into this room, which is determined by your social situation, impacts what happens to you in and after. Anyways, we're going to talk about specifically heart attacks. I'm looking at your comments. Ryan is asking, how do you cope if you lose a patient on a normal day? Well, we'll talk about that as well. That's a tough one. Nicole, Jamie, good to see you as well. Well, coping, that's always a tough one. The short answer is that it partly depends on what the circumstances were. Sometimes we have people cover for us because we need to step out. Would you ever want to be on an airplane with a pilot who just crashed a plane or just, had some horrific event happened? Would you want to go on an airplane with that pilot? On another flight with them before they had a moment to process what happened? Like, probably not. Unfortunately, sometimes anesthesiologists need to get right back in the game after something rough has happened. And we'll talk more about it if you want. But I promise today we're going to talk about social determinants of health in terms of your money and why money matters. We can change topics. It's a live stream for that reason. But you tell me what you want to talk about. And we're going to... Let's start with this study that came out just the other week about just how much your financial strain matters as much as your heart strain after a heart attack. Because it blew my mind how well they were able to quantify this correlation. Bottom line is, if you have a heart attack and you have financial strain after your heart attack, you're more likely to die in the next 6 months than somebody who had the same type of heart attack but doesn't have the same financial strain. Now it's like, wait, what? So this is why I'm all about natural medications wherever possible, because not only are they cheaper with fewer side effects, but they're more sustainable in the long run. Often have better composite outcomes than just one single medication. Of course, there's a lot of, there's more subtleties in that, but let me give you an example. The cost of a heart attack in the United States is anywhere from $10,000 to $100,000, depending on many factors. Do you need cardiac rehabilitation? Are you getting medications that are not generic yet, that are still on patent? Those can be very costly. You have to take time off from work. I mean, the list goes on and on of what goes into the expense after a heart attack. It is mind-blowing. Same for a stroke. Except for a stroke, you may have even more rehabilitation if you can't move and do your daily activities of living. Do you need to hire somebody to move in with you to help take care of you as you recover from a stroke, assuming you recover at all? So on and so forth. This can get very expensive. Now, when I'm talking about ways of preventing things, hopefully without medications, one, you can cut out the cost of the medications, which can be significant for many conditions, but more importantly, they have a better chance at prevention because we don't have a lot of medications that we give for preventing the first heart attack. We have lots of medications to help prevent the second heart attack, but not the first. That's where the beauty of integrative medicine comes in, where we have diet, nutrition, physical activity, social interactions, you know my list, of course, et cetera, et cetera. that can help go into preventing the first event, usually without medications, avoiding the costs there. And they can do more than just prevent the heart attack. They can prevent the stroke, prevent maybe, there's so many things that can help prevent more than just your heart and brain in terms of kidney damage, neuropathy, et cetera, et cetera. But the point is that we don't have good medications to prevent the first event. That's called primary prevention. That's different than secondary prevention. So with that said, I see so many comments I got to catch up with here. We'll talk about that, all those things in a little bit. So Kirsten is asking, can we talk about anesthesia and endoscopies? Like what exactly is used? Yes. Kirsten, hope you're still there. Let's talk about it right now in brief. For most endoscopies, I use propofol, which is this one here, and a little bit of this guy here. Can you see that? This, codeine is like the stereotypical cough suppressant, right? Well, all opioids can help minimize coughs. When you have an endoscopy, we don't want you to cough the scope right back out. So that's why I use a little bit of this, and then I also use a little bit of this as well to minimize the burning of the white medication as you're having the endoscopy. For colonoscopies, I don't use opioids because typically the pain is not needed. The pain is not high enough to warrant opioids. I just use the white and the lidocaine. Great question. All right. I don't see anything like social determinants in the cardiology office. Yes, Chem 7, you're right. We don't talk about this. I have a couple of videos on it, actually, like dogs. Just how much dogs, without any medications, no real side effects other than you to take them on a walk, how much they can even help prevent heart attacks and strokes. Crazy stuff. All right. I'm reading through these questions. Okay, Heidi wants to switch gears. When you're doing a shoulder block with a pain medicine ball, how can... Oh, okay. So Heidi's asking a good question about nerve blocks. All right, so we'll shift gears here from primary and secondary prevention of things like heart attacks and strokes, which is super important. I hope you guys learned a little bit about just how much the money plays into these things. Absolutely crazy how connected we are with the social determinants of our health, even in the operating room. So nerve blocks. Heidi is saying, how do we take out a nerve block? Well, we'll check it out. There's two types of nerve blocks that we do. I'm going to show you a needle for what's called a single shot nerve block. If I'm just doing a one-time injection, I'm going to place this needle. Can everyone see this needle here? This is the longer one, but you get the idea. It's 22 gauge, pretty thin. This goes into a part of your body where we're going to block the nerves. I do the injection with medications like this one here, lidocaine, which is not showing up very well there, but you get the idea. And it's a single shot. One shot of lidocaine with the needle, boom, done. This is in contrast to what Heidi's referring to with the ball, which is a natural pump that will slowly infuse medication to block the nerves over time. Now, that looks actually like an epidural catheter. It's called a nerve block catheter, but it's the same concept. So you place the needle first. I'll show you what that looks like. You place the needle first, like the one that I showed you. Then we thread a little flexible nylon catheter into that hollow needle. The needle is obviously hollow, right? Because you have to get medication through it. We thread through a little catheter like this through that needle, and this chills inside your body for a couple of days. We don't like to do it for more than typically 2 or 3 days because there's a risk of infection. And that little pump called the on-cue ball or the on-cue pump will let medication slowly seep in over time so that you have an ongoing nerve block effect. Great question, Heidi. Why is a mask used in colonoscopy and endoscopy? Jay, that mask provides supplemental oxygen because you're not breathing as well as you normally do when you have medications like this on board. Propofol decreases your respiratory drive. You don't breathe deeply in and out. So you need a little bit of extra oxygen to prevent you from having an ischemic event in your heart or lungs or any other major organs. Catherine says, my friend just passed at 39 from a massive heart attack. He was fit, a runner, good diet, no alcohol, no cigarettes. How is this possible? Catherine, I'm so sorry about your friend's death. This can happen for many reasons that we often don't know about. Man, I wish I knew the answer to that specific question, but everything that we talk about in medicine is for risk reduction. There's never such thing as 100% risk reduction. It's all relative risk reduction. And it's very important to remember that whenever we talk about medications or lifestyle interventions, none of them are surefire silver bullets. Remember, smoking is the most common cause of preventable lung cancer, but plenty of non-smokers get lung cancer as well, in the operating room coming for lung resections, even though they may have never smoked a cigarette in their lives. Likely comes from genetics and yet undiscovered external stimuli. Maybe it's something in the air that they're breathing, something in the food that they're eating, any number of things that we have yet to discover. By the way, that's why I always advocate for the most natural kind of living, because who knows what toxins are in the environment around us that we don't know about yet. Personally, that's one of the reasons why I am whole food plant-based, because, and this is its own whole topic we can talk about later, but animal products tend to bioconcentrate, just like how fish in the ocean bioconcentrate things like mercury. Land mammals do the same thing. I personally, this once again, personal preference, we can talk about it more if you want, but my view is that we don't know what toxins are in the environment that we live in now, because we have coal-fired power plants, industrial operations all over the world, et cetera, that are putting toxins in the environment that were not there 100 years ago. These bioaccumulate in the food that we eat. They end up in the air and water that go into our bodies, and these might cause some of the diseases that we see in the operating room that we can't otherwise explain. Like you were saying for your friend, heart attacks, maybe asthma, malignancies like cancers, etc. Great question there. And I'm really sorry about your friend's loss. Why is there a rhythm behind me? And there is no rhythm behind me on that monitor. There's nothing there. Okay. All right. Excellent. I'm looking at the questions here. The medicine ball was able to stay in for 3 days. So the medicine ball, Heidi's asking again about the nerve block catheter. We tape the catheter where it fits in your shoulder or neck for shoulder surgery, for example, with steri strips that are very, very sticky. Those will keep the catheter in there for a very long time. And obviously you don't want the ball to yank it out. So staying in your body for 3 days is actually very common in medicine. Usually they don't fall out if patients are taking good care to make sure they don't fall out. Hey, by the way, if you guys are learning things, do please hit that like button and share with others. And remember, as always, you have more power over your health than you've probably ever been told before. Shannon, good to see you. All right. Yes, Heidi, the on-cue balls are about the size of a softball. That's exactly the size that we use. Do masks help us avoid these toxins in the air? Shannon, highly unlikely. Good question, but highly unlikely. Michelle, thank you for the applause. Can I talk about thoroscopy? Yes. Or thoracoscopy. Yes. Well, first, Michelle survived her lung biopsy, so shout out to you, Michelle. I'm so happy that that worked out well for you. In thoracoscopy. So guys, the TLDR here is that anytime you see scopy, at the end of a medical word, it means that it's a camera stuck somewhere in your body looking at something on the inside. So we have endoscopies that go into your esophagus and your stomach, colonoscopies that go into your colon, thoracoscopies going into your thorax, laparoscopy going into your abdomen, and so on and so forth. I do laryngoscopy because I look at the larynx. So anytime you see oscopy, it means you're looking into somewhere inside your body that you couldn't see otherwise. Thoracoscopy is what we do for lung surgeries and esophageal surgeries typically. People that are having Nissen fundoplications for bad reflux, hiatal hernia repairs, resections of lung cancers, or sometimes blebs, people with COPD or Marfan's. Those are the most common things we'll do thoracoscopies for. The last thing would be things like mesothelioma that aren't really lung cancers, but still malignancy of the lining around the lungs and the thorax. All right. Ahan is eating an apple. I love it. I love it. An apple a day, baby. I love it. Shannon, do I ever do GI cases? Yes, all the time. It's why I told you my formula for endoscopies, and maybe you weren't here for that, but what medications I use for the endoscopies and what I do for the colonoscopies. Is laryngoscopy how they view the vocal cords? Yes, it is, Shannon. Yes, it is. Why can't induction meds work on erasing stored long-term memories for PTSD? So Catherine is asking about our medications for induction. The most common one in the United States is propofol. Other ones are ketamine, etomidate, and you can actually use anesthesia gas like sevoflurane as an induction agent. It's not IV, but it's still an induction agent. They render you unconscious in the moment. However, they do not affect the hippocampus and the other parts of the brain that store the long-term memories that you're referring to, Catherine. So just to be very clear, our medications here will cause anterograde amnesia, meaning amnesia in the future, but they won't cause retrograde amnesia or memory loss for most patients. There are some patients that are highly susceptible to what we believe are little blood clots that go into the brain to cause mini strokes that can cause long-term cognitive deficits and long-term memory problems. But that's not the objective of our induction medications. Those are unwanted side effects and complications from any type of surgery. I hope that answered your question. Unfortunately, we can't preferentially wipe out memories for PTSD. We can use lipophilic beta blockers like propranolol to recategorize memories that have caused PTSD, but that's not what induction agents do. Beta blockers are not induction agents for anesthesia. Great question. Cool. Michelle Peters, do you have any advice on how to avoid PTSD from a past surgery? Michelle, so I have a video on this coming out in a couple days. Yes, number one is you want to talk to your surgeon about your previous awareness episode. And two, you want to seek out psychological support as soon as possible. Now, you need to know that a past history of awareness increases the risk of future anesthesia awareness, which is why you need to tell your surgeon and anesthesiologist for your next surgery. There's a lot more that goes into this, but that's the most important thing to do without knowing anything else about your situation. I hope that helps. There are some more things to do as well about it, but they get a little bit more specific, and that's just with regards to like your body's ability to tolerate anesthesia and your anesthesia requirements. You can change those before you come into the operating room like the one that I'm in right now. All right. What is fluid resuscitation? Fluid resuscitation, Jay, is putting a bunch of salt water in your body or putting blood in your body as well to increase the volume of your intravascular fluid. That makes sense. So when you bleed out, you gotta put something else in its stead, otherwise your blood pressure will tank and you're at risk of heart attacks or strokes. Why do they place mesh over your baseball-sized hernia? Does it have chemicals in it? How is it safe? I don't place these. I'm not a general surgeon. However, over decades and decades of studying these meshes, it does not appear to confer a risk for the things that we've talked about, like neurodegenerative diseases, things like Parkinson's, ALS, Alzheimer's, nor cardiovascular disease, nor malignancies. There's always a risk of things that maybe one day they will find a connection, right? This has happened before for different medications. It is pretty rare, but you also have to weigh that against the risk of having a hernia that might pop, and you might have strangulated bowel, which might be lethal. So it's always a risk-benefit in medicine. Good question, Heidi. Yes, the body keeps score, Shannon. I do recommend that as well. Catherine, I'm not aware of research on the topic of anesthesia meds being used to wipe out PTSD. We already know that certain medications like ketamine can help reprocess traumatic events to help treat PTSD. So we already have things that can do it. It's just not the objective of induction medications in the operating room. Awesome. All right. The difference between LR and normal saline, you just got to read the ingredients on the bag. Every bag of fluid has the ingredients listed on there. Kirsten has to go. Well, I hope you learned something. And I wish you the best of luck for your upcoming procedures. What dose propranolol? I'm on it. Catherine, the dose of propranolol that I'm referring to has to do when you take propranolol with a therapist. It's not just taking propranolol. It is having propranolol in your body and then accessing that memory in a state of suppressed adrenergic activity, meaning no fright or flight. And that is one way of having your body recategorize that event instead of a trauma as a normal memory, so that it does not induce hyperarousal when it's accessed in the future. A lot of big words there. I hope that made sense. But propranolol is used in conjunction with a therapeutic intervention at the same time. Not necessarily people that take propranolol before flights or giving speeches, etc. Very different uses of that medication. Michelle had a panic attack when, yeah, Michelle, you're not alone to have a panic attack on the table. You know, let me just do it. Let me show you quickly that I am indeed in a real life operating room here. This is one of the tables that we use, and you're not the only one. That's why we're here. You're learning about ways that you can control your body to help snuff panic attacks before they blossom into full-on panic attacks. Take the anxiety, if you have the sense to, or if you're aware of it, if you can sense it before it fully kicks in, before it blossoms. It's hard to break a panic attack. It's much easier to stamp out the anxiety before it blows up into a panic attack. All right, guys, maybe the last two questions here, and now I'm going to have to go. So, ketamine-assisted psychotherapy, yes, Jay, I am involved with that as well. It's very powerful stuff. Propranolol does impact blood pressure, Shannon, you are correct. But at the doses used for that intervention that I'm talking about, they typically don't affect your hemodynamics or your blood pressure and heart rate significantly. Whenever I do that, it's with full-on monitors, by the way, for safety. All right. Okay, last question here, Michelle. As a chronic pain patient for 2 years and taking meds, will the doctor give me more sleeping pain medication? Okay. Yes, so Michelle is saying that, hey, I'm chronic pain. I have chronic pain, sorry. I take lots of pain medications. And even if they're not pain medications, pretty much anything that goes in your body, well, most medications will cross your blood-brain barrier, especially psychoactive medications like antidepressants, anti-anxiety medications, etc., etc. Of course, if they're affecting your brain, it means they're crossing your blood-brain barrier. As do substances like alcohol, marijuana, nicotine, etc. These all cross your blood-brain barrier. They're all making changes in your brain. Your anesthesiologist will know and should know how the medications that you take, whether for pain, depression, anxiety, etc., will impact your anesthesia requirements. Because remember, like we were saying last time, when your anesthesia requirements go up, your risk of awareness may also go up as well. So we need to manage that to make sure that you don't develop awareness that might lead to trauma after. All right, I hope that made sense. With that said, let me just do a quick grab bag here of, you know how much I love natural things here. I'm just gonna pick a medication at random. I'm not gonna look. I'm just gonna share with you what it does and if there's any plant analogs to it, because I love talking about plants even in the operating room, okay? So, all right, what's this one? All right, I picked lidocaine. Maybe it's boring. Hey, thanks guys for the kind comments. Lidocaine is notable as like one of the first medications ever used to help with pain. As you know, it was first discovered in South America that it would numb the plant leaf that I'm referring to. I don't want to say the name, but you know the plant leaf would numb people's oropharynxes when they would chew on it. It was then made into lidocaine, and that was used for all sorts of things like injection in the skin, for spinals, for beer blocks. It's a form of nerve block, by the way. Not B-E-E-R, B-I-E-R, epidurals, etc. Anyway, so it was very quick that we realized how you can transform that leaf into local anesthetics. Anyways, we also use them for the heart as well to prevent PVCs. Maybe you've heard of premature ventricular contractions, but sometimes patients under anesthesia will develop them in response to the pain, hypoxia, the hypercarbia, they're having sepsis, etc., anything can cause PVCs, and lidocaine as a sodium channel blocker can also help treat those. Anyway, it comes from a plant. We use it all the time. Maybe I'll do one more because it's so much fun here. Unless you guys have a specific medication you want me to do, I'm going to pick one at random, and then we're going to call it a day here. All right, so I'm just randomly kind of going through the medication pile here. Ready? All right, what's this one? Okay, everyone see this one? Zofran. So Zofran is like the classic anti-nausea medication. There is no plant analog for it, but lavender has a lot of the same properties. So Zofran was not derived from lavender, but it's interesting that lavender does have a similar mechanism of action, at least one of its actions. Probably why lavender as an essential oil, an aromatherapy that you inhale, can have anti-nausea properties. It can also have relaxation properties, which Zofran does not have. And anyways, so there's the Zofran. When we use it, I give it to almost every patient, assuming their heart can handle it. All right, that'll be it. Oh, Michelle's asking about Twilight. I'll have to save that one for next time, Michelle. But I hope you all learned something. We'll definitely talk about Twilight later on. In fact, I'll probably do a video on it, breaking down exactly what the difference is. Hey, Rouse, you're very welcome. I hope you all learned something. Remember that you have more power over your body than you've probably ever been told. If you learned something, please hit that like button, share with others, and I look forward to seeing you again on Alive soon. Why isn't aromatherapy used in the OR? We'll talk about that next time. We use it in pre-op, not in the operating room. All right, take care, guys. See you again soon.